Hi, everybody. How's everyone doing? All right. Thanks so much for coming out to this event. Really excited about it. We put a lot of preparation into tonight, and I think we have a event that's chock full of really good information, and hope you get a lot out of it. Tonight's event is called, it's the Tufts Medical Center Spine Center, Get Your Life Back. You have to forgive me. I woke up with a frog in my throat this morning, and probably the worst possible day to have it, but hopefully you can all hear me. So we have about an hour presentation. We have three spine doctors from Tufts Medical Center, including myself. We're all going to talk to you. We also have a community partner in the audience, Rich Mazzaferro. Rich, if you want to say hi. Rich is back there. He can answer questions at the end as well. And we're going to have two of our other spine doctors from Tufts talking as well. There'll be an opportunity to answer questions at the end as well, to ask questions. So I'm Ron Riesenberger. I'm the director of the Spine Center. And I'm just going to give you an introduction to back pain, my perspective as a neurosurgeon and spine surgeon. So, why are you guys all here tonight? Well, you're here because either you have back pain or neck pain or spine pain, or one of your loved ones has spine pain. And you should know that you're not alone. It's a very common problem. As you can see here, over 25% of adults will have suffered an episode of back pain over the last 3 months. So it's a very common problem. It's a very common reason why people miss lots of days of work, have disability. Those are difficult things for people to manage. Over 80% of people will have an episode of spine pain or back pain at some point in their life. So this is something that we see all the time and we take care of all the time at Tufts Medical Center. Some of the conditions we treat in our Tufts Spine Center, as you can see here are listed, include low back pain, neck pain, spondylosis. Spondylosis is basically a fancy schmancy terminology for arthritis of the spine. We treat disc herniations and spinal stenosis. Those are some of the most common conditions that we see and treat. We also treat more complicated procedures when necessary. We treat more complicated problems when necessary, including scoliosis, which is a deformity of the spine. We also treat spine trauma, fractures, tumors, and infections. Just another word about Tufts Medical Center in Boston. I just want to start in the middle. As you can see, we're a major medical center, and we're the major teaching hospital associated with Tufts University School of Medicine. A lot of medical students come over and learn from us. We take care of the sickest people in Boston. We have a level 1 trauma center. Level 1 is the highest level you can achieve, and that means we take care of the sickest and most badly injured patients. Just to give you another indication of the kind of care that we are capable of, our medical center has done the most heart transplants in New England over the last 10 years. So there's a lot of high-level care going on at Tufts. We've received a lot of awards over the years. We've received the 5-star rating from Vizient. That's an organization that rates the quality of care that's delivered from hospitals throughout the country, and 5-star is the highest you can achieve. We were in the top 10 for all hospitals across the country for quality. Leapfrog is another organization that measures safety, how safe hospitals are, and the highest level you can get is an A, and we've achieved an A rating. So I've been there for a long time. I think it's a great place. Now, when it comes to the Tufts Spine Center, we take a very patient-centered approach. So the patient is really at the center of everything we do, and we have 4 different divisions that take care of patients with spine problems. We have neurosurgeons like myself. We have physiatrists and physical therapists, orthopedic surgeons, and pain medicine specialists. And you're going to be hearing from an orthopedic surgeon and a pain medicine specialist in a little bit. Now, you've heard all this stuff about how great I think Tufts is. but it's over in Boston, which we know can be difficult to get to sometimes, and we've heard that feedback, so we've tried to send our specialists into the community so they can see you closer to home. So we have locations in Boston, Melrose, Stoneham, and we're also showcasing our Quincy providers tonight. So we have Quincy providers on Congress Street in Quincy, right here in Quincy. And our two Tufts providers there are Dr. DeCillier, who does pain management, and she's here tonight. She's going to be talking to you about non-operative spine treatment. And we also have Dr. Rogerson, who's an orthopedic spine surgeon, and she's going to be talking to you about surgical treatments of spine problems. Okay, so just as a general overview, as spine providers, we often think of dispensing care as basically a pyramid, all right? And there's a lot of people who come in, since back problems, spine problems are very common. There's a lot of people down here, and oftentimes all we need to deliver is first-line treatment, non-operative treatment, physical therapy, things like that. And when that doesn't work, we continue to go up the pyramid. And again, you're going to be hearing a lot of that from Dr. DeCillier about other treatment options. And that helps most people. And then at the very end, there are a group of people who are unable to get better with those lines of treatment. And surgery is the last resort, typically, for us. And you'll hear some more from Dr. Rogerson about surgery. So I'm going to hand over the mic to Dr. DeCillier now, who's our pain management specialist, seeing patients in Boston and Quincy.
Good evening, everyone. Thank you for being here. Hope we can answer some of your questions and bring some light on some of the topics that bothered most of you, obviously. It's true, Tufts has a lot of great doctors, and if any of you have been patients at Tufts, you're going to notice that a lot of the personnel there...
Just speak up a little bit. It's
Okay.
hard to hear you back here.
Oh,
Your mic isn't on.
I guess the mic is for the camera. I'll try to speak a little louder. So one of the great things about Tufts, it has amazing physician nurses, and for some of you, if some of you have been patients there, you're going to notice that a lot of people have been there for like 20, 30 years. And a lot of us who are, in our age group have been there for quite some time because we really love working together, and we think that the care is provided there is absolutely amazing. So pain is a complicated thing, and oftentimes is tricky even for us to treat, and despite our best efforts, sometimes we can only do that much. But being a complicated thing, every patient that shows up in our clinics, we're going to treat in a specific way, and everybody's going to have their own regimen based on what causes their pain. And they will be follow up, and they will have their regimen change accordingly. Just like Dr. Riesenberger was saying, usually in treating back pain, which we're going to approach mostly tonight, is a stepwise approach. And everybody, again, will have their own treatment because unfortunately there's not one size fits all type of regimen. So each one of you will come, will be assessed, will see what caused that pain, how long has that pain been there. And we're going to go with the easiest things first if you haven't tried them, and then we're going to proceed, depends on the results of the treatment. Most of the time, we start with simple things, and I'm sure a lot of you have in-house some ointments, you have some Aleve in the house, you have some Tylenol, so simple things that you can find over the counter at the pharmacy. There are a lot more creams nowadays, and I'm sure a lot of you have tried Bengay, a lot of you have tried some, Asper cream, Tiger Balm, I heard is really useful in certain circumstances. They have some newer ones like lidocaine patches, which probably some of you have tried. Now they have them over the counter for people to try. So these are the simple things. Usually this addresses limited type of pain as far as some muscle aches, new onset, something acute that is not very significant. And we just try this and see how it goes. Usually this regimen has to be, tried at least for a couple of days. Oftentimes nothing helps quite from the first pill or the first application of the ointments. Very important in any pain is to give your body some rest, and your body will tell you so. So whether it's complete bed rest or you take significant rest for a couple of days and only do the minimum things, eventually if you feel better, you will have to go back to your regular activities or work. Now, when people go to work, they have to keep in mind that, you know, their body tells them what to do, how much to do. So they're going to have to make some changes on their activities, on the way they work, on the way they do things, or they used to do things before. Some people cannot sit for a very long time. Some people cannot stand for a very long time. So everybody is going to adjust their level of activity according to what the body tells you to. Now, if giving your body rest to your own regimen doesn't work, that means we have to address this with someone that's a little more specialized. And this is where physical therapy comes into place. Now, to get referred to physical therapy, you have to go usually through your doctor. Therefore, the physical therapist will get a good idea of exactly what's happening and probably where the pain is originating. So the regimen they'll build up for you will be for that specific cause of your pain. Now, a lot of my patients are very good patients and very dedicated, so they want to get better. So they're going to do a lot more than the physical therapist tells them. And oftentimes, that might hurt them a little more. So I always say, do only as much as your body tells you to do. And the physical therapist will also adjust the regimen according to that. Aquatherapy is a great way of doing physical therapy, but that, you know, would be, depends on, you know, a particular condition. Some of the things the therapist will put in place is strengthening exercises, proper posture, massage, some other techniques that they could only use. Traction could be one of them. I personally had experience with cervical traction many years ago. I herniated a disc in my neck and I had typical nerve type of pain going down my left arm, weakness, numbness, tingling. And part of the regimen, and again, I want to emphasize that usually it's a mix of things that were put in place in your regimen. Part of the regimen was a cervical traction device, and I can swear by that. So I recommend to my patients when appropriate. For most of them, it doesn't work. I usually like the physical therapist to try first because some people don't like to have their neck stretched too much. And if they like, we can, you know, eventually provide them with some devices. Another form of therapy that a physical therapy mostly they use, and if you like it and you tolerate it well, there's a way we can prescribe it and have it at home for a more common use, is a TENS unit. This is a device that has little pads that are applied in that particular painful area that kind of like stimulates the muscles and the nerves in the area and helps relax and therefore provide with some pain relief. The indication for these are limited mostly to muscle-related pain or, you know, associated pain syndromes with some muscle spasm. The electrical current is intensity. It should give you more like a zing. It's nothing to be worried about, and everybody adjusted actually to their preference. I also use one of this when I had muscle spasm episodes, and what it did is it gives the brain a different message. So all of a sudden, because you can program it like half an hour on, half an hour off, all of a sudden you realize that, oh, I didn't have pain anymore. When it stops, oh, I have pain. So it doesn't really cure, but it helps along with other regimen. And if it has the right indication, it might be, you know, good for you to try. Now, bracing is a very popular thing, and I have quite a few patients that come either wearing the brace or asking for a brace. Well, it has limited indication, and what it does, you know, when it helps, it basically stabilizes kind of like the back, and if you have some associated muscle spasm, it kind of like keeps the muscles aligned properly, but it's not part of a cure, and you know, it's not always something that you should use for a very long time. So talk to your doctor if you think or you have a brace that you might want to use. Just talk to them and see if that would be a good thing to do. When none of these simple things work or the conservative work, then we probably have to think of, you know, some regimens that might be a little stronger and they go by prescription only. So your doctor will recommend some stronger medication that might be particular for that cause of your pain. Again, everything is, every pain is different and caused by different things. Oftentimes, back pain is a mix of things. So that's why we have so many medications that we can look into. So we have muscle relaxant. So a lot of times when something happens in the back, whether you herniate a disc or other types of pain, there's some muscle component to the pain because the muscles kind of react in sympathy to what's happening inside. So muscle relaxant could be one of the options. Then you see there are antidepressants and anticonvulsants. Now this is a class of medication that's extremely useful in pain management, but I don't want you to think that this is given for people with depression or people who have other issues. These are very valuable, especially in pain that have a nerve component. And it's not antidepressants that we use for this particular purpose are not at the doses they use for people with depression disorder. So they're used at much lower dose. And when we mix these into your regimen, we always look at the rest of the medication you're on to make sure there's no interaction with that. Corticosteroids are very potent anti-inflammatory, and oftentimes when something happens in your back, there's a lot of inflammation that we need to kind of like take care of. Usually the oral corticosteroids are not meant to be a long-term regimen. They're mostly for a week. But we can use these corticosteroids, and I'm going to talk in a little bit in a different form to help with the pain. Topical compounding creams, they're a mix of creams with medication. So compared to the Bengay, who has some menthol and something like this, these have medication in there. We can put a muscle relaxer, we can put a very strong anti-inflammatory, we can put local anesthetic. So these are very complex creams that we provide for particular pain purposes. And we can make a lot of creams for nerve type of pain, for muscle type of pain, for a lot of regimens. Non-steroid options, sometimes a real pain medication.
Made by the manufacturer? Or that
No, there are pharmacies who make these, the special pharmacies. They make, it's like old family-owned pharmacies, they make these things. They have pharmacists who are specialized in this kind of thing. And they have, different regimens, different recipes. We usually tell them, I want this, this, and this in there, and they mix them the way we want. And I have used them for various reasons, for many types of pain. And there are many pharmacies nowadays. It's a really new industry. There are a lot more compounding pharmacy that are coming out. We have a few that I work with. They have some of the smartest pharmacists, and if I need something, I think of something, I call them and they look it up and they come up with a mix. This particular pharmacy I'm working with mostly, I send them the prescription, they check with your insurance, and then they mail it to you overnight. So you don't have to go and pick it up anywhere. And that's one of the reasons I like, and they accept most of the insurances. So this is great for, this is great. And they call you after that, make sure you got it, make sure you didn't get a rash, make sure you responded, you like it. They call me and they tell me. So it's really good, for the patient. I love working with them.
facilities do use this too?
I don't know about other facilities, but we do. I hope so. I mean, I use this compounding cream myself, and again, it was very good. Like with anything, you have to have the right indication. If you have the right client, you give the right medication, it will work. So most of the patient, I would say, I'm not going to say 100%, but I would say 85% of the patient I prescribed the creams they were very happy with. But again, I had the right person. And I'm not big fan of pills because all pills are, they come with side effects. But if you have a knee pain and you can put that cream in there, it doesn't go through your stomach, it doesn't go through your liver, and it works what it's supposed to do. So now, when none of this work, and sometimes we might have to jump in from the beginning with certain injections. If you have chronic pain, you have severe pain, you have herniated disc, we have to move on to a little more aggressive regimen, and that includes injections. We do a lot of forms of injections in our clinics, and the most common one that you probably heard are the epidural steroid injection, facet injection with radiofrequency ablation, sacroiliac joint injection, trigger point, which are probably the most common ones. Trigger points are indicated when there's muscle type of pain, and again, the muscle type of pain could be associated with some underlying condition, but oftentimes it just happens like that. And I'm sure a lot of you, if not all of you, have felt knots somewhere in your neck, in your shoulders, in your back throughout the years. Now those are muscles go into spasm, and when they go into spasm, they kind of shorten and they limit your movements, and they give you a lot of pain. Sometimes massage or massaging some of those creams help, but sometimes the pain is so intense and limits your activities and sleep and all that. You might need injections like this. These injections go into that particular knot that we feel. We always assess and see where the pain is, where it's tightness. Sometimes by pressing on that particular knot elicits the pain. And we put, the needle is very tiny, but the mix of local anesthetic with a little bit of cortisone might be a little, giving you a little burning sensation. Oftentimes, I have to say, the pain relief is immediate. Patient feel a huge difference immediately. Now, depends on how long this problem has been. Sometimes they might need to be repeated, and again, I can never tell you you're going to need 3 or 4. We'll see how you respond after the first one. I have patients that I see a couple of times a year. I have patients that I see every 2 weeks for a while, and then every 2 months, and so on. So everybody's going to get their own regimen on that. Do they go on their own? Oftentimes not really. That's why we have to help a little bit with some injections. Now most of the injections we do are image guided. That means they're not blind. The trigger point injections we feel and we go with the needle in, but deeper injections in the spine, they're always image guided. That means we have particular spots that we want to be in, and we have a certain type of image that guides our needle exactly in the spot we want. So we make sure that we get the response we want. And epidural steroid injection is one of the most common, and I'm sure you've heard some of you about it. Now, this has an indication, the type of pain that we all call sciatica. So it's pain going down the leg. This is usually due to a herniated disc. Now the discs are those blue lines here in between the vertebrae that kind of like keep everything aligned. Sometimes, for whatever reasons, whether we do a big effort or wrong movement or something like this, they herniate. That means some of that middle part of the disc pushes out and pushes on one of the nerves. Now that nerve becomes very infuriated, aggravated, and we have to do something about it. So one of the things that we could do if no medication or physical therapy helps is doing this injection. Again, the injection we do under image guided, so we see exactly where we're going, and depends on where your symptom is, which part of the leg, the front, the back, it will guide us towards the proper and the best place to put the needle in. Sometimes the leg pain is associated with numbness and tingling. If it goes to have some weakness, that means it's a little more significant. We have to do something about it a lot sooner. If it's associated with something called foot drop, that means you have problems walking or lifting your foot, we might need to send you to a surgeon a lot sooner than we think. The epidural steroid injection are injection that put cortisone, which is a very strong anti-inflammatory medication. So instead of taking a handful of oral cortisone, we turn that into a specifically made medication and we put it there, and it's supposed to stay there and coat the nerve area and reduce the inflammation. This way the nerve cools down and it doesn't give you that pain message anymore. How often do we have to do it? Depends. Again, everyone will have their own regimen, whether we have to do it once or we have to do it 2-3 times, depends on what caused the pain, how long has the pain been there, and how you respond to the first injection. That would be, again, a very personal regimen that we'll make for you. Another common cause of back pain, especially in the 70s and 80s, is what we call facet arthropathy. So the little joints in between the vertebrae, we all start developing bone spurs as we grow older and wiser. So at some point, we're going to have some back pain, especially trying to straighten our spine or getting out of bed, or when we try to do the dishes. So that prolonged standing creates some pain across the lower back. Most of the time is due to these little joints. Now, how do we address this as far as injection? This is a 2-step procedure. First, we're gonna do what's called facet joint injection. So we're gonna inject where we think the pain is coming from, and we'll see how much pain relief you get. If you got a good pain relief, that means we can go exactly in the same area and address those little nerves on top of the joints by doing a procedure called radiofrequency ablation. Now, this sounds a lot more sophisticated, and it sounds very terrifying when you think of burning the nerve. Now, that little nerve is a very little nerve, and it's not a sensory nerve, so it doesn't involve any, it's not going to give you any weakness down the leg or anything like that. But that nerve gives the message of pain from these little joints. So we just go and pretty much kill the messenger. And we do this procedure, and again, image guided. It's not any different than the initial procedure. We just have to do some testing, so it's going to take a little longer. None of these should be painful. So usually the pain relief from this procedure lasts anywhere from 6 to 18 months, depends on the level of activity, and it's always recommended that physical therapy is part of the regimen when we address this particular condition. Now, one other common pain issue is sacroiliac joint, and oftentimes people feel pain in the buttock area radiating into the groin, sometimes going down all the way to the leg. This could be from the sacroiliac joint. This is a very quick, very common injection. Again, with image guided, the pain relief is almost immediate. How long would it last? Again, depends on how long you've been having that, if you've done any therapy, and so on. Most common, the injections are repeated in pretty much everything, but how often we repeat this injection depends on what caused your pain, how did you respond to the first one, what are the treatments you had. So I want you to see the injection as a part of a regimen that will be personally created for you when you come to the clinic. If none of these work, or if it's acute, very serious condition where, like I said, you have foot drop, you cannot walk, the pain is so significant, the nerve is crushed, then the next option will be surgery. And I will invite my colleague, Dr. Rogerson, who will talk to you about these options, and will answer as many questions as you have at the end.
Hi, everyone. Thanks for coming out tonight. I appreciate everyone's attendance and learning a little bit more about our Quincy Spine Center. So this is me and my PA, Brett. So we have started seeing patients up in Stoneham, and we've been doing that for about 2.5 years now. So we are kind of used to this, seeing initial consults and doing surgical planning and stuff closer to home, and then possibly taking surgery into Tufts, and then doing all the follow-up in the community out here. So I think it's kind of best of both worlds. And we've been doing this for about 2.5 years now, and I think we have a pretty good system, so we're excited to get this more kind of off the ground here in Quincy. So I'll speak to you tonight about 3 different conditions that we treat surgically, probably most commonly and we're gonna focus on the lower back. We take care of everything basically from the base of the skull all the way down to the pelvis, but tonight I think our focus will be on lower back conditions. So I'll kind of pick up right where Dr. DeCillier left off with and speak about disc herniations for a little bit. So the good news is the vast majority of people are going to get better without needing surgery. Surgery is really reserved for only the 5 or 10% of people with the disc herniation that don't respond to all of these conservative treatments that Dr. DeCillier outlined. Medications, different types of injections, physical therapy, and really just time while your body takes care of that disc herniation. So for those small percentage of people, either they have a neurologic deficit, and we talk about surgery a little bit sooner, like Dr. DeCillier talked about, if you have a foot drop, or if patients' leg pain or numbness or weakness is refractory to these conservative treatments, then we'll start talking about surgery. And that surgery is called a microdiscectomy. I think most people have probably heard of someone who's had that procedure done. So we do them as a day surgery. I try to do them very early in the morning, so you're up walking around that afternoon and you go home actually the same day. It's done through a very small incision in the middle of your back, right over the level of that disc herniation. As far as the post-op recovery goes, again, you go home the same day. And I limit heavy lifting for about 6 weeks. Usually people that have a desk job are back to work within a week or so. A lot of times people can work from home now, so I have a lot of patients that will, take the weekend off and then they can work remotely from home after surgery if they have a long commute or something like that. For patients that have a little more demanding job or require a lot of lifting, then I may keep them out for about 6 weeks to really just avoid heavy lifting. So again, this is a sort of a diagram of what the surgery entails. We've already made an incision in the skin, come right down on the level of the disc herniation, move the nerves aside, and simply remove that herniated disc fragment that's pinching that nerve and causing the leg pain. So again, this is probably on the whole spectrum of spine surgery, this is on the sort of least invasive end of things. So again, day surgery, up and walking right away, and a lot of patients that have a strong component of leg pain will notice relief within a day or two. The next common condition, and a little bit more invasive than just a simple microdiscectomy, would be a surgery called a laminectomy for spinal stenosis. So spinal stenosis occurs when you develop spondylosis or arthritis in the spine that starts to encroach on the area for the nerve roots. So when those facet joints that Dr. DeCillier was talking about start developing bone spurs, it's the same process as getting arthritis in your knee or your hip or your shoulder. But the problem is with these facet joints, it occurs around nerves and causes problems in your legs. So patients with spinal stenosis, you may get relief if you're walking in a grocery store by leaning over a shopping cart. That makes more space for the nerves. Patients with spinal stenosis can usually only walk or stand for a couple minutes before their legs will feel heavy. They may have a component of pain or weakness, or their legs will feel kind of like jelly, like they're going to give out. They'll sit down and those symptoms will go away. So those are pretty classic symptoms of spinal stenosis. And again, these patients will go through the whole gamut of conservative treatment, and if they don't get any better, surgery is always the last resort. And that surgery is called a laminectomy. So it's a little bit more of a decompression or removing that arthritic tissue than simply shaving away a little bone to access a disc herniation. So in this type of surgery, we're actually removing a lot more of that arthritic tissue and making space for all of the nerves kind of running down the center of the spinal canal that you see there. The recovery for a surgery like this is, as far as my restrictions and stuff go after surgery, is almost identical to the microdiscectomy. Patients are generally back to work maybe a week or two after the surgery. I limit heavy lifting for about 6 weeks, so no more than a gallon of milk in each hand, just to allow those muscles to heal. Again, desk work in a couple weeks, and manual lifting, more labor-intensive jobs I'll keep out for 6 weeks. Patients that undergo a laminectomy tend to be a little bit older than patients that undergo a microdiscectomy, so they may require, and it's a little bit more invasive surgery, so it may be a night or two in the hospital. It'll depend on how well these patients mobilize with physical therapy. And again, you're going to be up walking, hopefully the day of surgery, if not the following morning.
Is that just if it's one level? Or what if there's
Yeah, so you kind of hit the nail on the head when it comes to spine conditions. So sometimes we can do a one-level laminectomy. Other times, it has to be multiple level laminectomy. That's why all these sort of the recovery time is very generalized. And we, like Dr. DeCillier said, all of our recovery, the hospital stay, it's all going to be very tailored to what each patient needs. So sometimes it is just a simple one-level laminectomy. Other times you need 2 or 3 levels to address all the levels where the nerves are compressed. So it's a good question. So moving sort of next level in the next step up in level of invasiveness would be when we have to start involving hardware and start doing fusion procedures. So when there's instability or abnormal motion between the bones in the spine, you require a stabilizing procedure, like these X-rays show up here. So those are rods and screws to stabilize each segment. And again, this could be a one-level surgery, or this could be a multiple-level surgery. The surgical technique, much like the non-operative stuff that Dr. DeCillier said, is going to be tailored to each patient's needs. So some patients, I think, are great candidates for a minimally invasive approach. Others, a more traditional open approach. And it really depends on symptoms and how many levels we're addressing, and how much surgery each patient can tolerate based on their medical comorbidities. So what we talk about in the next several slides is very generalized. And I try to make it sort of as least specific as I could, but I'm happy to take any other questions about specific.
Does the fusion limit your
Motion?
mobility
So
compared to before you had the fusion?
So I think the short answer to that is no. So a one-level fusion like this, people don't really notice any real change in their mobility as far as their spine motion goes. I honestly think people probably move a little bit better after this because their nerves are free and they don't have the leg pain, and the back pain may be a little bit better once the surgery is healed, and people actually seem more mobile after this than kind of protecting yourself and stuff. So when we start doing fusions all the way down to the pelvis and up into the thoracic spine, that's when I really counsel patients that you're going to notice stiffness in your spine. But for 102 level, typically not.
You're going to notice long-term stiffness after the fusion if it's multi-level?
If it's multi-level, it's going to vary a lot patient to patient. So once we start fusing down into the pelvis, I think is when people really notice stiffness. But for when we're sticking to just 1 or 2 levels like this, I don't think people notice a lot of long-term stiffness or anything. That's not generally what people come back and complain about or talk about in their 1 or 2 year follow-ups. So. The other thing, when we start talking about fusions, every surgeon has kind of developed and refined their own technique over time. So Dr. Riesenberger and I both do the same sort of procedure. Our x-rays may look the same at the end, but the way we go about it is maybe a little bit different once we get into the operating room. So if you're seeking multiple opinions, especially around Boston, you're going to find a lot of different ways that surgeons will treat the same sort of MRI findings and same kind of symptoms. So that doesn't necessarily mean there's one right or wrong way. It's just many different ways to approach a problem. Okay. So as we start doing fusion procedures, I think I keep the lifting restrictions on a little bit longer. Patients are in the hospital maybe a little bit longer, but again, this is all very patient specific, and it depends how well pain control goes after surgery, how well you mobilize with physical therapy, and when you're safe to go home. So anywhere from 1 to 3 nights for a 1-level laminectomy infusion is pretty average. So kind of back to my previous point about there being multiple ways to approach each problem. I think if you do find yourself as a surgical candidate, either you or a family member, I think it's important to find a surgeon that you sort of connect with, that you both understand the clear goals and expectations of the surgery, and they're kind of treating you as a whole person and not just your MRI findings or your X-ray. Like I said, there are many, many ways to achieve the same outcome, so I think it's really important to find someone that you're comfortable with. So depending on what the surgery is going to entail and what each patient's medical comorbidities may be, I may have patients come up to Tufts and see our anesthesiology department for a pre-op appointment, go over medications, go over their heart history, and make sure that all of our pre-op testing is in order before we proceed with what could be a significant surgery. There's also a program at Tufts where we first select patients, particularly over the age of 65, where general anesthesia may be sort of risky for those patients. General anesthesia can be associated with confusion and trouble with controlling blood pressure and things like that after. So we do spinal anesthesia for some of our older or patients with more medical problems. So that is also an option that we do at Tufts as well. I'd like to share with you now a patient story of mine. So this is a patient that I just saw for her 1 year. I already kind of gave away what happened there with the x-ray slide, so I apologize. A patient of mine that just came in for her 1 year follow-up. She's a nurse in her early 60s. This is from my other clinic up in the Stoneham area. She described those classic symptoms of heaviness in her legs when she stood or walked for really any more than 3 or 5 minutes. She had to sit down and take frequent breaks at work. And so just really those classic symptoms of spinal stenosis. She agreed to let me use her story in this presentation for you guys. This is her MRI and her x-ray findings. So you can see here, this is the central canal where the nerves are located, and she has that narrowing here at 2 levels around those nerves. So I felt that those 2 levels were responsible for that heaviness that she had in her legs. And the x-rays that I get before surgery, I always take with the patient standing up. So MRI is done, if anyone's ever had one, is done laying down in the MRI machine. So when you stand up, sometimes you can see that sort of step off that you see between each level. It becomes more pronounced when you stand up. So it sort of accentuates that narrowing around the spinal nerves. So I felt that her symptoms really correlated very well with her imaging studies, and I felt that she was a great surgical candidate. I was like, slam dunk, you're going to get a lot better right after surgery. She was terrified, and she put it off for about 6 months, and finally came back, and she was like, all right, Dr. Rogerson, I'm ready, let's do this. So she's probably one of my happiest patients, and now she's a year out. So this is what we did in the OR. So like Dr. DeCillier mentioned, she does all of her injections with either ultrasound or x-ray guidance. I also use x-ray in the operating room. So when I'm placing all of my screws, that's all done under x-ray guidance. I mark the levels using x-ray. So this is a little sequence going through her procedure. So this is my sort of take on a minimally invasive laminectomy infusion. So you can see on the top left here, I already have 2 screws in. I'm working on the next level and drilling that level. Once I have all the screws in, I check them. I put them in sort of looking from the side, and then I flip to another view and make sure that they look good in 2 planes. And then I finally finish the laminectomy part, which isn't exciting to show on an x-ray because it's just me kind of removing arthritic tissue for an hour or 2. And then I finally put the final fusion construct together. So those are her final x-rays. And so she's now, like I said, a year post-op. She returned to work since she is an ICU nurse, and if anyone knows a nurse, lift a lot of patients. It's actually a very manual job. So she stayed out for the full 3 months, but went back, full time right after 3 months. She had some mild back pain when she walked, but really her leg symptoms completely resolved basically by her 2-week post-op visit. She also enjoyed ice skating, and she sent me a nice Christmas card with a picture of her ice skating last winter. And she really was walking unlimited distances at this point. So it's quite a change from only being able to stand for 3 to 5 minutes before having to sit down. And now there's a picture of her with her son after they went for a hike. So there are a lot of common misconceptions about back surgery. And I think a lot of our techniques have changed over the years. A question that I frequently get is, am I going to be on bed rest after surgery? And the answer to that is no. We like you getting up, walking right away. We found over the years, the longer you lay in bed, the more prone you are to blood clots and pneumonias and urinary tract infections. So really mobilization is the key part of the recovery process. Physical therapy. Yes, you're going to work with physical therapy in the hospital, and depending on what type of surgery you had and how mobile you are after, you may do some outpatient physical therapy at the 4 to 6 week mark after surgery, depending again on how extensive your surgery was. And some patients are doing great at the 6 week mark, and they're like, you know what, I don't want to go to any more physical therapy. I'm good. I'm walking. I'm all set. So it's not mandatory after, but you will have it if you do stay in the hospital. Physical therapy will work with you. Back braces, like Dr. DeCilia mentioned, have kind of fallen out of favor. It kind of goes along with the mobility thing. It's hard to move when in the hospital after you've had a fresh back surgery and now you have this brace on. So we really try to stay away from braces unless in a small subset of maybe trauma patients or something I'll put in a brace. But for my elective procedures, like the patient story that I showed you, absolutely not, no braces. And again, if there's one thing that I want you guys to kind of take home tonight after this is that we really don't have a one-size-fits-all approach. Spine conditions can be straightforward and simple, like a disc herniation, or they can get really complex pretty quickly. And really, there's no sort of one way to approach every patient, because every patient's different. Your demands are different, your jobs are different. Your medical conditions are different, so I think we really do a great job of trying to tailor our both non-operative and operative approaches to each individual patient.